It's my pleasure now to introduce our BNPA medalist, Professor Rob Howard. And Rob really needs very little introduction, Professor of Old Age Psychiatry at UCL. And really, Rob, over decades, really has made a unique an extraordinary contribution to the treatment of Alzheimer's disease, really leading the pivotal trials in the area. And I can't think of anyone better to bring us up to speed with developments, controversial developments in the therapeutics of Alzheimer's disease, which many of you will have heard about. And you'll hear about them from the manufacturers of the drugs, but I think we also need to hear about them from academics who understand the field and don't have a commercial agenda. So Rob, I will present you with your medal after your talk. I've come to retrieve it from here and I'll keep it safe until you're done. So over to you, thank you.
Well, thank you, Jeremy, and thank you, the BNPA. And I should say I've never actually won a medal before. In fact, I've had a career totally lacking in any kind of winning or distinction. I think the only other prize I have is Most Improved 6-year-old, which I got a book about St. Paul when I was at school. And if I tell you that it was from a very low baseline, I think it was really to try and encourage me to continue improving rather than because of any outstanding promise that I showed. But thank you for that. So yeah, so should we be preparing to give new dementia treatments to our patients? We've waited for so long, haven't we, for treatments that will make a difference in Alzheimer's disease. And we all have a vested interest in Alzheimer's disease and its treatment, because between a third and a half of the people in this room, you'll have Alzheimer's disease when you die. We're all living so long. The greatest risk factor for dementia is being elderly. It's going to be a part of all of our lives and the lives of our families. And what do we want from dementia treatments? We really want something that will slow or stop neurodegeneration and stop the functional decline that we see in our patients. We'd be happy, actually, if we could just improve cognitive and behavioural symptoms more than we can at the moment. So you'll be aware that the cholinesterase inhibitors and memantine are symptomatic treatments. They very modestly improve the symptoms of Alzheimer's disease. But if you look at what happens in Parkinson's disease, symptomatic treatments do a fantastic job, don't they? They give you at least 10 years of really hugely improved function. We don't really have that with our Alzheimer drugs. Now, here's a point I'm going to bang on about later. The magnitude of the treatment effect must be clinically meaningful. The magnitude of the treatment effect with the cholinesterase inhibitors and memantine is only just clinically meaningful. So that's kind of set the bar for what we need to see. It's pointless having a treatment that's expensive, painful to take, carries risk, an unpleasant sort of adverse risk profile that doesn't really make a noticeable difference, a worthwhile difference to patients. The treatment should be safe. It needs to have a good safety profile, not only when you're giving it immediately, but also in the long term. And as we'll see, there are some questions about long-term safety about the treatments that are being sort of pushed through at the moment. Treatment should be straightforward to administer within services. And I don't mean to be unkind to my colleagues who work in memory services, but we struggle to get all our patients onto cholinesterase inhibitors or memantine. So it's really important to stress how easy it must be to administer any treatment that we have. At a time when the budget for health, certainly for mental health, services appears to be shrinking rather than growing, it's also really important that these treatments are cost effective, that we can demonstrate that by giving a treatment we're going to save money either in terms of health or social care use. There's not going to be new money available for these treatments. Just as there wasn't new money available for setting up memory services, we raided other parts of our service to fund the establishment of memory services. And then finally, there's the kind of Whitnall and I. So if you remember that film Whitnall and I, Whitnall and his friend are in a tea room in Penrith one afternoon. They've been sent to buy Wellington boots, but instead they've spent the money on going to the pub. And they waltz into a tea room and they say, "We want the finest wines known to humanity. We want them here and we want them now." And there's an element, I think, of Whitnell thinking in our approach to these treatments. Of course, we want fantastic treatments for our patients. We don't want to wait for them, and we want to be able to have them in our clinics. So we have the cholinesterase inhibitors. They're the mainstay of the treatment of Alzheimer's disease, and they tick some of the boxes in the list I've just gone through with you, but obviously we'd like more. But if you just look at the panel on the left, what I hope you can see is the change in the ADAS-Cog. So the ADAS-Cog it's like an expanded mini-mental state. There are 80 to 90 items, depending on which variant of it you use. And here I hope you can see these are people who got 5 milligrams or 10 milligrams of donepezil. These people got placebo. The first 6 weeks, everyone appears to get better because of placebo effects. But you'll see the people who got donepezil deteriorated, but quite slowly. And those who got placebo, well, after their initial placebo response, just continue to deteriorate as you'd expect. And I can remember 20 plus years ago when this graph appeared, we studied it closely and convinced ourselves that, look, the slope of decline seems to have been altered. We convinced ourselves that maybe because of the symptomatic improvements, patients were able to engage more with the world and stimulate their brains, and that protected them from neurodegeneration. Of course, if the company who published this had been honest enough to join up the lines with what happens when you withdraw and have a kind of placebo phase at the end of the trial, everyone ends up the same. So there was no real change in disease course. It's just purely symptomatic treatment, even though it's dangerous to look at slopes of graphs because they can give you the impression of disease course modification. And some of us were involved in this study. This is part of the Domino trial, in which people with Alzheimer's disease who've been treated with a cholinesterase inhibitor, starting when they had mild to moderate dementia, of course, had declined to the point where they were at that sort of moderate to severe transition point, where NICE advised at the time that the cholinesterase inhibitor should be withdrawn, and patients were randomized to either carry on with donepezil or to come off and get placebo for a year's treatment. And we followed all the people in that trial for 4 years to see what happened to them in terms of their transfer into a care home. And what this is a kind of survival graph, and you can see if 100% of people were in a care home, we'd have been up here. At the beginning, no one was in a care home. At the end of 4 years, you can see about 70 or 80% of people were in a care home. But at every point during those 5 years, the people who've been withdrawn to get placebo were more likely to be in a care home than those who've been able to carry on with their donepezil. Remember, this was double-blind for the first year, and the risk of going to a care home was doubled in the first year in those patients who had been taken off their donepezil. So you could argue that donepezil had actually modified the course of their illness. It certainly modified the course of what happened to them as a consequence of having their illness. So I'm labelling this point because it's quite difficult to sort out whether your treatment has really altered the course of the underlying disorder. We know that donepezil doesn't actually change the course of the neuropathology of Alzheimer's disease, but it can appear to change the course of the disease. And as a psychiatrist, it's very strange to work with a disease where you kind of understand the neuropathology and the underlying pathophysiology. And I can remember when I was thinking about, should I become an old age psychiatrist? I wasn't led into it by an interest in dementia. I was really very interested in patients with paranoid disorders. But I can remember being quite envious of my friends who were doing work in the kind of molecular biology of Alzheimer's disease. And it seemed there were so many potential points along the amyloid pathway that you could intervene. It just seemed, surely, it's only a matter of a few months or a small number of years before we have treatments that interfere with the amyloid deposition process and that make a difference to the course of disease. Actually, it's only really been the anti-amyloid antibodies which contribute to clearance of amyloid that have really made it past the kind of starting post. And this is a very depressing list of sort of phase 2 and phase 3 trials in Alzheimer's disease based on the amyloid hypothesis. And all you really need to know is that with 1 or 2 exceptions, they've all failed. So BACE inhibitors haven't worked, gamma secretase inhibitors haven't worked, they make it worse. And the huge majority of anti-amyloid antibodies also, I'm afraid, haven't worked. So I'm going to just divert for a second to talk about the the clinical dementia rating scales, the CDR. And the reason I want to talk about this is this has become the kind of main outcome measure that's been used in the industry trials of anti-amyloid drugs. And the reason it's been used is because the FDA used to say, we will only license a dementia treatment if you can show that your drug improves cognition and one other area, be it quality of life or activities of daily living. But they sort of relaxed a bit and said, actually, if you can find a composite measure that includes cognition and activities of daily living and quality of life, then you only need to show a change on that one scale. And so this is the scale that's become the kind of industry standard. And I just basically just introduce you to it briefly because it's important to understand what a score on this scale means. So there are 6 domains: memory, orientation, judgment and problem solving, community affairs, home and hobbies, and personal care. And in each of these domains, you get a higher score if you're more severely affected. And you can see the questionable impairment only gives you 0.5. And I have to say, I'm probably already scoring in the questionable. Many of us, I'm sure, are, if we're honest about it. I haven't yet reached mild, of course that's going to happen eventually. But you can see a move from nothing to my state would be a score, will give you a score of 0.5. And the score from each domain is totted up, and so it's possible to score anything between 0 and 18 on this scale. And this has been used to basically have a sort of staging categorization of people with dementia from normal, 0, which I've already told you isn't me, right through to 18, which is severe dementia. So what you need to really understand when we look at the slides that are coming is that this is a scale that ranges from 0 to 18, and I've shown you what a change of 0.5 in just one domain would look like. So after all those failures of Alzheimer's disease treatments, you'll remember there was a huge amount of excitement about aducanumab. Aducanumab was a sort of cursed drug because the manufacturers, Biogen, had this terrible problem that when they set up 2 almost completely identical trials. The difference between them is that one started a month after the other. But all the inclusion criteria and everything else were exactly the same. So they make a big deal about how different they are, but they're basically twins. And as I got told off for saying, the trouble with twins is that there's always an evil one. and this was the problem with Engage and Emerge. So when you look at these graphs, going up is a bad thing. Going up is decline on the CDR. So this is a score, remember, that goes from 0 to 18. And you can see there were in both the trials, there were 3 arms: a placebo arm, a high-dose arm, and a low-dose arm. So it's an intravenous infusion. And what I hope you see when you look at this is that basically everyone in the trial got worse. And actually the difference between treatment and placebo is really, really small. And, you know, we have to accept that there's a statistically significant difference between the placebo group and the high-dose aducanumab group in Emerge, but in Engage, there wasn't. Really very difficult to know what to make of 2 large, well-conducted trials, both of which were stopped early for futility, but which were allowed to report, one which apparently gives a positive result, and the other which gives an absolutely clear negative. But when you looked at what aducanumab was doing in the brains of patients in the trial, it was doing a fantastic job of clearing amyloid. So there's no doubt that if you just use biomarker outcomes for aducanumab, you'd be delighted that the drug had done what you wanted. So if I just take you through this, the left-hand side panel shows you baseline amyloid PET scans, where amyloid, as you know, is red on these scans. And the right-hand side shows you the year later amyloid PET scans from placebo, and then increasing doses of aducanumab. And I mean, there's no doubt when you get to the highest dose, there's almost complete removal of red. So there's no doubt aducanumab clears amyloid from the brain so people with Alzheimer's disease. And on the basis of that, the FDA were able to give accelerated approval to FDA in the treatment, to aducanumab in the treatment of Alzheimer's disease, because they said there are good reasons to think that biomarker shift would lead to treatment effects. But actually, when the FDA's statistician looked to see if there was a correlation between the change in amyloid on the PET scans and apparent improvement in the CDR sum of boxes scale, there was no correlation. And in fact, clearing amyloid with aducanumab accounts for about 2% of the variance in cognitive scores. So almost completely unrelated. So aducanumab was a kind of a bad story because nobody could really explain the positive and the negative trial, and really the differences were just so small and disputed because the trials had been stopped and everything else, and the company really couldn't claim that they got a positive result. And also Biogen behaved extremely badly. They hid the data and were very slow to publish it, and in fact waited until after they'd got the accelerated approval from the FDA before they published, and then they published in a journal that basically allowed them to not make any changes in response to reviewers' comments. I can tell you they did actually submit the paper to JAMA initially, but refused to make the changes that were demanded by the reviewers and the editor, and so they pulled the paper and sent it to an easier to publish journal. But now we're moving forward to the end of last year, and lecanemab. And so lecanemab, the Clarity AD trial, which I'm going to show you a little bit about, much more convincing, statistically significant positive result. And you remember there's a lot of publicity in the papers, people saying that this was a historic change. I suspect the word historic came from me. I was asked by the papers, I said, well, my head says, no, sorry, my heart, that's not my heart. I've got a heart and a head. My heart says, this is really historic and amazing. We've got a drug which has actually worked. So that's my heart. My head, unfortunately, says the effects of treatment are so tiny and the difficulty given the drug is so great and the potential side effects are so great that it's difficult for my head to really be excited. But the papers only went with what my heart had said, unfortunately. And the great thing about lecanemab is that Eisai actually went to quickly publish. They've been very open about the data. They behave much better than Biogen, who of course are their close friends and partners. And a good thing about New England Journal of Medicine publications is that they will produce a sort of research summary. So you don't need to read the whole boring paper. You can just look at the summary and you can get what you want. And the most important aspect, of course, of any trial is what happened on this primary outcome. Oops. And sorry, I didn't mean to jump so far. So here's the primary outcome. So this is the worsening on the sum of the clinical dementia rating scale sum of boxes that I showed you, the 0 to 18 scale. And here's the lecanemab participants, and here's the placebo participants over 18 months. And what I hope you can see is there's a separation which actually starts pretty early, probably far too early for a disease course modifying effect to be manifest. But remember, again, with caution, because I showed you the donepezil curves and how they appeared to diverge, donepezil placebo, we can definitely see what looks like a divergence. And we end up with a 0.45 difference in the clinical dementia rating scale at 18 months. So this is good, this is exciting. But, the graph I've just shown you, look at the y-axis. I mean, they've really stretched things out to show the separation. If we remember that this is an 18-point scale, and we look at actually what the difference is over the whole life, whole career of someone with Alzheimer's disease, you can see it's a really, really modest difference. It's a really modest difference. But there were a lot of outcomes in this trial. I just want to focus on the two that I think are the easiest for us to visualize as clinicians. The first is that clinical dementia rating scale sum boxes, which I showed you. So the difference was between drug and placebo was 0.45 of a point. So remember, it's an 18-point scale. And the minimum clinically important difference on that scale is 1 point. And I'm going to talk a bit about MCIDs and how they're calculated. So we've got a difference which is about half of what's conventionally accepted as the minimum clinically important difference. And for the ADAS-Cog14, the difference is 1.44 points. It's a 90-point scale. And again, the minimum clinically important difference on that scale is generally accepted to be about 3 points. So I think minimum clinically important differences are really important, and that as doctors we're not particularly good at looking at them, and of course drug companies hate them and don't want us to know about them or think about them. But they make a lot of sense, don't they? What is the minimum change with treatment in a patient that you could notice as a clinician and would make you think, gosh, that treatment was worthwhile and has made a difference? And there are 3 ways of calculating the MCID. The first and easiest way is to look at the standard deviation of the change score that the treatment has given you and halve it. And remarkably, that simple step gives you something which correlates pretty closely with the other ways of calculating the MCID. The other 2 ways are you get together a group of people in a room like this and you argue out as experts what you think would be the minimum clinically important difference. What would be the difference that you would notice, that you would regard as significantly important? And you involve expert patients and you involve people who look after expert patients, caregivers too. And you come up with a figure that you would all agree by consensus is the minimum clinically important difference. But then the third and most sophisticated way is an anchoring method, where you look at trial data where the scale that you're interested in has been used, but there's also been a kind of global assessment of patients. So you can look at the people in the study who were considered by the people doing the ratings to have globally improved or worsened by the smallest amount that's detectable, and you can then correlate that with what were the changes in those particular patients in the score that you're interested in. So the graph I'm showing here, these are the results of a study where the researchers looked at a vitamin E study, which of course did nothing in Alzheimer's disease, but it provided a rich data set of people who'd had both the CDR sum of boxes, and it also had a kind of global assessment of change by people in the study. So you could pick out from that population of people in that large trial all the patients who clinicians thought had deteriorated by a noticeable degree during a 6-month or 1-year period. And you could then look at, well, what was the corresponding change in the CDR sum of boxes in those particular patients? And what they found was that the minimum clinically important difference that associated with that noticeable change was different in patients at different stages of dementia. So people who are normal, it was about half a point. People who had mild cognitive impairment, thought to be caused by Alzheimer's disease, it was 1 point. People who had mild AD, it was 1.6, and people with moderate severe AD, it was 2.3. So when you use the scale that was the primary outcome in the lecanemab study, these are the changes that you have to see if you're to see a clinically detectable difference in a patient. I hope you've understood that. And so Kathy Liu, who's a colleague of mine, actually looked at what we know about MCIDs in Alzheimer's disease. And all I would basically point out to you is, well, here are the figures from that paper I've just shown you in MCI, mild Alzheimer's disease, and moderate severe. But here's also the mini-mental state changes that will be considered to be a minimum clinically important difference. And again, they get bigger as the dementia gets more severe. And here's the ADAS-Cog change for mild Alzheimer's disease of 3 points. It's been shown from previous studies. And so now that we understand about minimum clinically important differences, let's have a look at the results from the anti-amyloid antibody trials. So remember, I told you that the Clarity trial is the one that was positive. So here it is here, with its 0.45 clinical dementia rating scale advantage. But if you look at all the other
up here is the EMERGE trial, the good twin from the aducanumab trials. What I hope you can see is that actually most of these trials had a pretty similar kind of effect. But the Clarity AD trial had much tighter confidence intervals. And does anyone know why that was? It's a bigger trial. It's not a better antibody. It's just a bigger trial. And the problem with very big trials is they can give statistical significance to a tiny difference that probably isn't clinically relevant. So, I'm just really struck by how similar these drugs all are, really. And here is the minimum clinically important difference. And of course, lecanemab comes with risks. So ARIA, amyloid-related imaging abnormalities. There are two kinds of these. ARIA-E, because Americans don't know how to spell edema, and ARIA-H, which are initially hemosiderosis, but can actually be associated with quite nasty hemorrhages. I mean, these MRI scans would make me very anxious if I saw them in one of my patients. And if my dad had Alzheimer's disease and had one of these treatments, and I saw this had happened to his scan, I would be agitated, I think, probably to say the least. These are not trivial side effects and differences. And if you look at what happened in the Clarity AD trial, so as a trialist, I'm always interested in not only things that go wrong because they are bad for participants, I'm also interested in things that go wrong because of the potential for unblinding. And actually, you imagine these people were having fortnightly infusions. More than a quarter of the people who got lecanemab had infusion reactions, which would have effectively unblinded the participants and the people in the trial centre. So I think that's important. ARIA-E, you can see, and ARIA-H occurred in about, let's say, sort of 12, 14% of people. Symptomatic ARIA-H, so that means there's a kind of hemorrhage or something rather nasty that's vascular on the brain scan, and the patient has symptoms. I mean, to me, that's a stroke. If I have a patient and something happens to them, they're different, and I do a scan and there's something vascular and nasty on the scan, that's a stroke. So a little bit less than 1% of people have a stroke. And why is this? This slide shows, so the green staining is for actin, which is in the smooth muscle in blood vessels. The red shows amyloid, and what you can see is that amyloid replaces smooth muscle in blood vessels in the brain in Alzheimer's disease. So unsurprisingly, when you remove amyloid with an antibody, it changes the blood vessels and makes them more fragile. And 3 patients on lecanemab have died because of lecanemab. They didn't die during the randomized placebo-active drug comparison. They died during the open sort of post-trial extension period. So these are either people who were they've been on placebo during the trial and then been exposed to lecanemab, or people who'd not had lecanemab for a while during the trial and were then re-exposed to it. And the 3 patients were all also taking blood thinners, so they're not kind of typical. But this is terrifying, isn't it, to see a scan like this in a patient? And these patients tend to die very, very quickly once these things happen. I'll just skim quickly through these, because I think it's important to say that there is, of course, a counter-argument to the one that I'm trying to sell you this morning, because you'd have thought, wouldn't you, that a less than minimum clinically important difference efficacy, safety concerns, and all the problems associated with trying to administer these drugs would mean that NICE would have a really easy job when they come to consider these drugs. But I think there are 3 things that are said in defense of them. The first is that we may have set the minimum clinically important differences too high. Second, that if these drugs have actually modified the course of disease, it may be really unfair to judge them on what they've done in 18 months. It may be that we should be thinking about what happens at 5 years. And then finally, I'm afraid the Whitnell argument is strong. If there's a treatment, we want it. We should let our patients decide rather than us being paternalistic about it. And these have been sort of encapsulated in sort of recent publications about this and about what exactly is the clinical meaningfulness. I should just point out the caveat is the people involved in these papers are heavily associated with the trials and with industry, or with the American Alzheimer's Association, who are just kind of crazily pro-treatments, I'm afraid. So they argue that a 0.5 CDR sum of boxes difference is clinically meaningful. I mean, I just don't think that's right. They argue that with true disease modification, the true benefits have been underestimated, and they produce these kind of models to show if you were to see a 25% slowing, which is about what we see with lecanemab, if it really has slowed, then the equivalent delay that you see just gets greater and greater as the months and years go by. I would argue that it's really dangerous to extrapolate beyond what we know from clinical trials. One of the things that frightens me, and several other people too, is the amount of brain volume loss that patients who get these treatments seem to suffer. So in the lecanemab trial, people lost 15, let's get this right, 3 teaspoonfuls. So that's 15 mils, isn't it, of brain volume during the trial. So that can't be good. I mean, for a long time, we used brain volume as a sensitive measure, didn't we, of dementia progression. So I can't help wondering if that's going to lead to more trouble further down the line, maybe an accelerated decline later. And I also think it's really important to question, have we convincingly shown disease course modification with these drugs? I don't think we have. The only way to do that is either with a withdrawal design, and I showed you what happened with the cholinesterase inhibitors when they're withdrawn, or with a delayed start design. And in a sense, the open label extensions that we have of these drugs are an opportunity, really, to do a delayed start, because the people who have placebo during the trial are now exposed to the drug. We should be looking in that cohort to see, do the people who had the 18 months of treatment before the open label extension, do they do better than those who've had that delayed start? So my friends who are involved in these studies say, so far, both groups look exactly the same. It doesn't look like there's a sustained benefit. And then we want them here, we want them now argument. I mean, I have a great deal of respect for Simon Mead and Nick Fox. They're excellent sort of dementia neurologists. And it's difficult to argue against. There are millions of people who just want a treatment and would want to take the risks and want to do everything they could. But my own feeling is they need to be protected against the risks that go with these treatments. So the FDA granted accelerated approval of lecanemab in January, and they're likely to grant traditional approval. There are applications for licensing in Japan, the EU, and the UK at the moment. I just don't see how NICE could deem these treatments cost effective. I also just don't see how we can possibly set up services that can give these treatments, even if we thought it was worthwhile. So I'll finish now by saying modifying the course of AD biomarkers turns out to be easy, but it's not clear that that leads to clinical course modification. If any of these agents get marketing approval in the UK, that is going to come with a huge amount of uncertainty for us as prescribers and also for our patients. It's really important that companies should maintain the blinding of previous allocation during open extension phases, because these can be used as delayed start trials. They can answer whether we really are seeing disease modification or not. And then finally, we know that neuroscience and our understanding of disease models advances all the time. Thank goodness, because we deserve better than these treatments. We do. We deserve better models and better treatments. And so I guess the answer to the question I posed at the beginning, should we be getting ready to give these treatments, is a no, but I'm optimistic that better treatments are coming and will come. Thank you for your attention.
Thank you very much, Rob. We've got time for some questions. Chris.
Thank you very much, Eddie. Thank you. That was really, really beautiful talk. Thank you. Just 2 questions, if I may. One very quick point of clarification. Was there a correlation in the Clarity study between the improvement on the CDR sum of boxes and amyloid clearance, as there wasn't in the earlier ones? And then the second question is about, if there is licensing for lecanemab, what is that going to do to future trials of novel agents if it becomes, the standard of care against which we have to compare everything else and getting patients into new trials of new medications? Thank you.
So the answer to the first question is we don't really know, but probably not. The standard of care question, yeah, well, obviously, if it becomes the standard of care, it will have to be given. But I think from what I've shown you, I think it's highly unlikely these treatments will become the standard of care.
Thank you. A question from the online audience from Narinder Kapoor. Is it the case that there's no such thing as a true placebo trial in dementia, in that patients will always have side effects on the drug arm and will always be aware that they're on the active drug?
Yeah, well, so, I mean, yes, but you'd be amazed how many people get side effects on placebo. And if you've been involved in a drug trial, I'm always struck by the people who demand emergency unblinding because of side effects who turn out to be on placebo. So actually, the preservation of blinding is better than you'd think. But I do think having an infusion reaction or an ARIA-E event is a pretty gross unblinding.
Professor Hodges.
Very interesting, thank you. Watching all this on the sidelines. Is this emphasis on amyloid a sort of modern delusion of people, in that there's kind of early brain shrinkage and there's massive synaptic loss, and it's clear that sort of removing amyloid from the brain doesn't really make much difference? And if there's huge synaptic loss early on, what are possible treatment interventions that could conceivably make a difference?
Yeah. So I would argue that these trials are the ultimate test of the amyloid hypothesis, and it hasn't really stood up well. So unfortunately, the field has been so overshadowed by interest in amyloid, it's been really difficult for people to get funding to do other things. And we're not very imaginative as a research community, I'm afraid. So we need new models. And you're right, we need to understand what happens, why synapses deteriorate early, sort of pre-amyloid damage. But the only way to do that is to have a more diverse basic science research portfolio than we have at the moment. I mean, my slight anxiety about some of these drugs getting licensed is that, of course, that then incentivizes drug companies to pile in to have Me Too drugs. And we're going to end up with a kind of delay in looking elsewhere. I'm always a bit disappointed when I see how few late-phase trials there are for non-amyloid type treatments.
We've got time for one more question, and that goes to Dr. Blackburn.
Thanks very much. That's an excellent talk. The question I have is the minimal change and the temporal relationship. We see people with prodromal Alzheimer's disease progress so slowly. Do you think there's a better scale that you use that could work? And the second thing is, do you think the noise with people progressing fast and slowly just means it's so hard to detect difference and that it might be clinically meaningful for some patients?
Yeah, I think the noise is why we need to think about minimum clinically important differences, because the noise makes it difficult. There is less noise early on than later, interestingly enough, which is why the MCIDs are smaller early. It's possible to detect reliably smaller changes early on than it is later, even though I know that sounds counterintuitive given the way you phrased your question. The difficulty, I think, with looking very early is that we find lots of people who don't have Alzheimer's dementia and aren't going to deteriorate. And those of you who follow me on Twitter or whatever will know how exasperated I am by the kind of high-profile examples that were given to people with dementia who clearly haven't got dementia. And we need to be much more honest about how we get it wrong.
Great. Thank you very much, Rob. I remember I bumped into John Hardy at the conference in San Francisco in December where the lecanemab data was announced, and he told me he was there for the victory lap of the amyloid hypothesis. So I think you told us that he hasn't quite got to the finishing line.
I once got told that. Be careful, because I'm all that stands in the way of John Hardy getting a Nobel Prize.
So look, I think you've more than earned your BMP medal, which I'm going to present to you in a moment, and it is a medal for outstanding contributions to neuropsychiatry. And although you are an old-age psychiatrist, you are also a neuropsychiatrist, because I think you're famous for saying that old-age psychiatry is neuropsychiatry, but with a job structure, a career structure. So let me present this to you now. Thank you. Can you have a photographer? Yeah. Yeah, you should. There we go. Okay, we'll run with it. That's fine, that's good, great. Thank you very much. Good.
So,